Okay, that sounds good. So, welcome everyone. My name is Marina Pinheiro. I'm an NHMRC Early Career Fellow at IMH, and it is my pleasure to chair the session today. But before we start, am I in the right screen now for acknowledgement of country? Yeah, I'd like to acknowledge that I'm joining this meeting from the lands of the Darug and Guringai people, the traditional custodians of this land. And I pay my respects to elders past, present, and emerging, and recognize and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I know that we have people joining from all parts of Australia here today, so feel free to put in the chat the lands that you're joining from today. Um, Today we're going to have a seminar that is being organized by the Centre of Research Excellence in Prevention of Falls-Related Injuries. That's our second seminar. And the topic for today is practical implementation of the falls prevention guidelines in residential aged care. For today, we have three speakers, three fabulous speakers, and we're going to hear from each of them. They're going to have about 10 to 12 minutes, some maybe 15 minutes presentations. And then at the end, we're going to have time for questions and for a discussion. So we ask yourself to save your questions for the end. You're also welcome to put your questions on the chat. And during the presentations, we're going to ask you to mute yourselves so we can focus on the speakers. Our first speaker of the day is going to be Suzanne Dyer. So Sue is a senior research fellow at the Flinders University. She has a lot of experience, more than 20 years experience with evidence evaluation, health technology assessment, and guideline development. She's an author on both the World Falls Guidelines, but also the Australian Falls Prevention Guidelines. And she's the lead author of the recently released Cochrane Review of Interventions to Prevent Falls in Older People Living in Care Facilities. So you can see that she's definitely the right person to be talking to us about the topic today. So let's welcome Sue. I'll stop sharing my screen so you can share yours. So thank you for coming today, and I'll hand it to you, Sue.
Thank you, Marina. So let me just get the slide view. Yeah. So as Marina said, I'm going to be talking to you about the recently released falls prevention guidelines that have been updated and released in June this year. But I'd like to add that I'm presenting from the lands of the Kaurna people, who are the people of the Adelaide Plains. And so first I need to acknowledge that there's a huge amount of work and a lot of people that go into developing the falls prevention guidelines. There's 4 main authors, but a huge number of people, particularly from the falls CRE and associated researchers, did a lot of the work evaluating the evidence that goes into it, as well as many rounds of critical review and consumer input and so on before the guidelines were finalised. The guidelines were released by the Australian Commission on Safety and Quality in Healthcare. So you can access the guidelines at this website. And I wanted to point out there's actually 3 separate guidelines for different settings. So there's guidelines for hospitals, residential aged care that we'll be talking about today, and community care. And for each separate setting, there's several documents available. There's a really brief fact sheet, which is basically 1 double-sided page. There's the complete guideline, which is about a 30-page document. And if you wish to access all the background research that goes into the guidelines, the evidence behind the recommendations, you can click on the bottom of the form and receive a copy of the background reference documents. So the structure of the guidelines, as I said, for each separate setting, there's evidence-based recommendations, and there's also a large number of good practice points that address all of the falls risk factors that are laid out below. And I won't have time to go into all of those today, but I do encourage everyone who's implementing these recommendations in aged care to go to the full guideline and to familiarise yourself with the good practice points. And as I said, you can access the background reference documents if you wish for more detail on what the evidence is informing different recommendations and good practice points. But just briefly, the evidence that informs the recommendations for falls prevention in care facilities basically come from an in-progress update of the Cochrane Review to prevent falls for older people in care facilities that we were in the process of updating while the guidelines were being developed. And so the main evidence used was to December 21, and we were doing a lot of work at the time, and a lot of that's informed the guidelines was published as separate publications that you can see here. And then also the Cochrane Review itself has been published only a few weeks ago in late August, and that has updated evidence for falls prevention in care facilities. The conclusions are very consistent with what's informed the Australian Falls Prevention Guidelines, with just a few more trials because the evidence is to December 2024, and a little bit of extra detail around implementation of some things, but I'll show you a couple of those key things today. So within the guidelines, every evidence-based recommendation has a level of evidence. And just to explain what they are, there's a number which is level 1 or level 2 evidence. So for level 1 evidence, the benefits of the intervention clearly outweigh the undesirable effects, and these should be implemented whenever possible. A level 2 recommendation means the balance between the benefits and undesirable effects are a little bit closer, and so they might be considered differently for different people. And really, it's a weaker or more conditional recommendation. You need to consider the context for each individual person about whether you're and how you're implementing that recommendation. There's also a letter, which is the quality of evidence. So high is very strong evidence, this recommendation is unlikely to change. B is intermediate evidence. If there's a lot more research, it's possible that it may change. It's also likely that it might just change the confidence in the estimate. And the Australian guidelines are only based on level A or level B evidence. Level C isn't used. So as I said, for each setting, and here we've got residential aged care services, there's a fact sheet, which you can see here, which just summarises the evidence-based recommendations, and that's what I'll go through today. But there's also the full guideline that includes all the good practice points. And just to show you an example, here's the page for the multifactorial or risk assessment, and you can see there's the evidence-based recommendation at the bottom left there, and then the good practice points, which does give some detail about things to consider and how to implement these. So I encourage everyone to have a good read of that if you're implementing them. But to summarise the main evidence-based recommendations, so the first one is that multifactorial or multifaceted falls prevention strategies based on an individualised risk assessment should be undertaken for everyone. So that's delivering a package of falls prevention interventions based on an individual falls risk assessment, and this needs to include consideration of both personal risk factors, so things like medication review and medical review, but also an environmental risk factor assessment. So consideration of physical things that can cause falls in their bedroom and also in the common areas of the facility. But also consideration of physical aids, so things like whether people need glasses or mobility aids. Now, in delivering this falls prevention package, what's important is that it's not just an individualised selection of the interventions, but how they're delivered is truly individualised and tailored. So, for example, if someone does need new glasses, and if they've got dementia, do they need help in keeping track of those glasses? How are we going to do that? Do they need help in using a new mobility aid or keeping track of that? And what we do have strong evidence for now is that for these package of interventions to work, we know that educating and involving the workforce in delivering the falls prevention package is critical for the falls prevention interventions to work. In the guidelines, we've now got much stronger evidence that exercise is effective at reducing falls for older people in care facilities. But again, it should be individually tailored and designed and delivered by a health professional, so a physio or an exercise physiologist who's trained in falls prevention. Very importantly, though, we've got strong evidence that this exercise has to be ongoing. So we can't just go in and deliver a 6-week or 2-month exercise program and then expect that to be reducing falls down the track. The exercise really needs to be integrated as part of usual care and ongoing, because once we stop the exercise program, those benefits disappear, which is actually not that surprising when you think about it. Now, as I said, the Cochrane review was published only a few weeks ago, and this includes a little bit of extra evidence to what was informing the guidelines, and in particular around exercise. We've got a little bit more information in the Cochrane review about the type of exercise programs that can prevent falls. So we know that the types of programs more likely to prevent the number of falls are moderate or low intensity group exercise programs. And in fact, most of the trials that reduce falls were providing moderate intensity exercise. And also that we need to deliver exercise for at least an hour a week for people who are mobile, whether that's with or without a walking aid. So I think we can see from that the type of programs perhaps that sometimes are encountered that might involve sitting on a chair, hitting a balloon around for 15, 20 minutes a couple of times a week isn't actually going to meet this kind of standard of the type of exercise we need to be delivering. And in the Cochrane review, we've also got evidence that exercise might reduce the number of people falling amongst those with cognitive impairment. So it's really important that these people are included in exercise programs whenever possible and when they're willing. So to move on to the other evidence-based recommendations in the guidelines, they are that menus should include at least 3.5 servings of dairy food, so things like milk, yogurt and cheese in the diet daily to meet protein and calcium requirements. And in the involvement of a dietitian is what happened in the trial that was shown to be really effective. So we know that people don't eat a lot of food often, so simply giving them extra food is going to be difficult to achieve that. So a dietitian may need to be involved to help incorporate these dairy foods into the diet. We already knew that vitamin D supplementation is important to prevent falls in this population. So we know that older people in care facilities don't get outside often enough. The vast majority are vitamin D deficient. So it can just be assumed they're all vitamin D deficient. They should all receive supplementation on a daily or weekly basis. And it's not required to confirm that they're vitamin D deficient. That should just be standard care. There's also recommendations that those with osteoporosis or history of low trauma fracture should be receiving the appropriate medications. And there's a lower strength of evidence for the use of hip protectors, so they can prevent harm from falls. But I think everyone involved in aged care knows that you need to consider the individual resident, whether they're likely to comply, whether this is likely to be effective or something they're willing to do in using hip protectors. So a summary of the new version of the guidelines compared to 2009. Since then, the changes are that there's an increased emphasis on delivering the interventions that are based on that risk assessment, ensuring they're individually tailored and involving the care staff in educating them and delivering the interventions. We've got stronger evidence for the effectiveness of exercise and a new recommendation on the importance of dairy foods meeting protein and calcium requirements. We've still got some of the same recommendations from 2009, which are those multifactorial interventions, vitamin D supplementation and osteoporosis medications and the use of hip protectors. And of course, there's a large number of good practice points. And just to finish off, sure everyone here is aware, but to remind everyone of the importance and the harm that comes from falls. So just older people living in residential aged care, 26,000 are hospitalised every year, and just over 30% of residents fall every quarter. And to remind you that this is where you can access the guidelines, and I encourage you to go and have a good read of the full guidelines that include all the good practice points. Thank you.
Fantastic. Thank you so much, Sue, for a very comprehensive and clear presentation. So thank you very much. I'm sure you all have questions for Sue, but let's hold on to the end of the session. We are going to now move on to our second speaker. So our second speaker is Dr. Jenny Hewitt. So Dr. Jenny Hewitt is a clinician, researcher, and educator. She has extensive experience in this area, and just a couple of examples that I have picked here. She has led a successful trial on exercise for falls prevention in aged care. She was also an expert witness for the Royal Commission into Aged Care Quality and Safety, providing evidence on the best practice allied health. And she now works in Whedon Research Hub team, designing, testing, and scaling new approach to reablement and positive aging. So now let's welcome Dr. Jenny Hewitt. So if you'd like to share your screen, that would be great. Thank you, Jenny.
Everybody, just bear with me while I share the screen. So as Marina said, I work now for Whedon. We have 24 residential care homes and 10 community regions across New South Wales, predominantly in rural and remote areas, but a few in Sydney as well. And I have this fabulous job, which is basically translating best practice allied health from research into practice. So like many of you, I attend the New South Wales Falls Prevention Healthy Aging Network event every May if I can manage it. And that has allowed me to see what's coming. I was able to have a look at the draft guidelines when they were publicly released, and I saw a presentation back in 2023 about what was sort of coming. And I'm so relieved, Sue, when you've presented now that the things that we started to implement last year were based on what was those works in progress. And I will now be mapping our approach at Whedon to falls prevention to what's been published in the Cochrane and in June. But this work that I'm about to share with you started in 2023 and 24, where I was asked to sort of build a new practical way that Whedon was going to approach falls prevention for our homes spread across such a large geographic footprint. So I took a look at that time at the draft national guidelines that have been released in 24 for feedback, the World Health Organization resources on falls prevention, some world guidelines, and sort of honed in on the how-to from some of the successful clinical trials. After that, took the tools I'm about to show you for 3 of our homes to test, and then got feedback from the staff and looking at how this new approach to individually assessing risk and tailoring interventions, how that worked, and then use their feedback to scale across the organisation which we launched in the 2024 April No Falls Month. So that involved mandatory training, we had big events, and then we've been reviewing and refreshing sporadically since then. So it's a bit of an iterative process. So the studies that we decided to, because there are so many key recommendations and we're trying to get people, I mean, I'm passionate about falls prevention, and if you're in this room, you're passionate about it, but we're trying to get people on the floor, frontline staff, to really engage with what they can get their teeth into a few key points, because at the same time, the palliative care team are asking people to focus on best practice end-of-life care. The wound management team are doing the same, and so there's a lot of information going out. And I decided to really focus on a few points. So one of them was based on Pip Logan and the team's work, which was the All-in Education that Sue mentioned earlier. So educating staff about known risk factors, and whether you're clinical or non-clinical, you might see something if you know what to look out for, and be able to report to the clinical team and hopefully get in front of a fall. So we developed a education program that I'll talk through in a moment. And we focused on food as medicine, we called it, using that study that Sue mentioned about the 3.5 serves of dairy per day. So really getting the kitchen staff to notice if plates coming back half eaten, getting the AINs to report, if somebody's maybe just eating their greens but not touching their dairy, we want to know that sort of thing. So how to actually implement this in the real world. And then the falls prevention exercise program, that's kind of one of my things, my baby. So I wanted to make sure that the progressive resistance and high challenge balance work was being scaled across the organisation. And we don't have gyms in all of our homes. So how are we going to get that dose of individually prescribed moderate resistance training and high challenge balance at scale. So we've implemented, we call it Exercise for Life, and it's twice a week ongoing across all of the homes. So we called this entire program Live It Up because falls prevention is a bit negative Nelly and the term. So we tried to think of something that wasn't stay on your feet because we love that, but it's registered and trademarked. So we ended up with Live It Up. So get up, stay up, and live it up. So back in the April 24 Falls Month, we had mandatory training for all staff. It's short videos with quizzes at the end, and there was one for clinical teams and a different one for non-clinical teams. The sort of things we taught everybody was about what were known risk factors. So this is adapted and based on Pip Logan's GTAC, or Falls in Care Home risk factor checklist, but we did include a few of the newer items like, are they eating 3.5 serves of dairy per day, and so on. What type of exercise are they doing? Not just are they exercising, because a lot of places do walking groups and seated exercise, but that's just not going to cut it for falls prevention. So we had this. It was basically a laminated sheet that we would send out when someone was due for a scheduled review, or if they'd had a fall, to see if any of these risk factors were relevant. Then they bring it back, and we had this great A3 page where you match the risk factors that were identified here to some practical suggestions. So that's sort of based on the way that Pip Logan's team did it, but as I said, with a few more customised items for more recent work that wasn't in that original GTAC tool. So we ask people to tick the actions that are most likely to help this person. So sometimes you get every risk factor ticked, but the person tends to fall, between 6 and 7 in the morning. So maybe the ones we'll focus on, we're getting them out of bed earlier and making sure that they're up, rather than just ending up with a really academically perfect long list of actions. We wanted them to choose 1 to 5 priority actions that we were going to hand over every shift to make sure and do it in that sort of breaking it down into bite-sized pieces. Sue mentioned that we'd sort of need to look at the intrinsic and the extrinsic factors. So the sort of things we also looked at were staff involvement. For example, are we having a whole lot of people falling around the 10 o'clock time, and then discover that the staff are all going off to have their morning tea break together? Do we need to look at rosters? Have we got enough people on at the key times of the days? One fall we identified when we had several people in the room from different parts of the business. So the housekeeping group were in the room. We'd have multiple falls in one room and discovered that they were using a new cleaning product on the floor. If we didn't have everybody together and discuss those practical things, we would have been able to address that. So what about the training for non-clinical people? We spoke about the dairy food. We spoke about the type of exercise that people do. We spoke about glasses. A lot of the residents still had multifocal glasses, and so when they're walking around, and that little section at the bottom is magnified a lot so that they can read, when they're not reading and they're walking around with those glasses, it's blurry on the floor. So we spoke about that type of thing. Some of the things we noticed when we worked with the dementia care teams was they were talking about increased agitation when people were too hot or too cold in the memory support homes. So we included, making sure that we've set the temperature in the room to suit the residents, not, perhaps some menopausal stuff or kitchen, or, in the middle of summer in the Northern Rivers when we're all humid. So it was quite holistic. There were 4 little videos released, 1 per week for the month of April, that spoke about these, and they were played for the residents as well as for the staff in the staff room. And we had an event in every home where yummy options for the dairy were presented, and non-dairy options that still had the similar macros in terms of calcium,